So we've talked some, actually quite a bit, about health policy. You might be wondering, what about mental health policy? Now we are going to move to a brief discussion of mental health policy, specifically focusing on historical context and the quest for parity or equal coverage between health insurance benefits and benefits for mental health needs. Within the historical context, I want to spend a bit of time talking about what kind of has transpired around caring for people or providing services for people with mental health needs. So back in colonial America, there was lack of specialized treatment, and individuals with mental health needs were viewed as both as an economic and social concern rather than having medical issues. And so what typically happened is that individuals with mental health needs were housed in the homes of relatives or others in their community at the public expense. It became increasingly obvious that there was a need for specialized care for individuals with mental health needs, and this particularly became apparent as the population increased in the United States, and then, of course, subsequently, the number of individuals with mental health needs increased as well. And so we saw the rise of specialized psychiatric institutions, and Dorothea Dix was really the leader in making this happen in the late 1800s. She conducted research to look at the status of individuals with mental health needs who were institutionalized. And at this point, the institutionalization was occurring without any specialized care or treatment. She identified many abuses and was able to strongly advocate for specific state institutions that would be able to provide necessary services to adequately care for individuals with mental health needs. She was able to secure 135 million acres for state psychiatric institutions. She also had worked to create federal institutions or have federal land designated for this purpose, and that proposal went quite far in terms of the process through Congress and otherwise, but was vetoed by President Franklin Pierce. And so for quite some time, we saw institutionalization as the main way of providing services for individuals with mental health needs. However, in the 1960s, we started to see a movement toward deinstitutionalization and the rise of community mental health services. And specifically, I want to highlight the Community Mental Health Act of 1963. President John F. Kennedy signed that into law, and the Community Mental Health Act drastically altered the way that mental health services were delivered in the United States. Specifically, this policy authorized federal grants for establishing public or nonprofit community mental health centers, and these centers were meant to provide comprehensive mental health services. And really, this act came in response to evidence suggesting that mental health needs could be treated more effectively in the community and also more cost-effectively. It also led to many individuals with mental health needs reintegrating in their communities. However, it is also important to note that the deinstitutionalization was in some ways a rather slow transition, and state psychiatric hospitals were still in the process of closing and reintegrating individuals back into the community into the early 2000s. I wanted to just show an image of a state psychiatric hospital. This is Mayview State Hospital, which is located in Bridgeville, Pennsylvania, a little bit outside of Pittsburgh. And Mayview actually went through a large institutionalization process in about the mid-2000s. So in addition to the historical context for mental health policy, where we went from institutionalization to community reintegration, there has also been a lot of discussion about the quest for parity. And again, when I'm talking about parity, I'm talking about the equity in terms of ways in which health insurance providers treat physical health needs versus mental health needs. And so we saw for a long time that physical health benefits were more easily accessible than benefits for mental health needs, that it became very prohibitive for individuals to access treatment for mental health needs and or substance use needs. And so in 2008, we saw the Mental Health Parity and Addiction Equity Act be passed, and this act required health insurers and group health plans to provide the same level of benefits for mental health and or substance use treatment and services that they did for medical and or surgical care. We saw further movement on the issue of parity from the Affordable Care Act in 2010. And so the Affordable Care Act actually further expanded the requirements set forth in the Mental Health Parity and Addiction Act by ensuring that all qualified plans offered on the health insurance marketplace covered behavioral health treatments and services. Finally, I want to highlight a 2016 Centers for Medicare and Medicaid rule. This regulation from the Centers for Medicare and Medicaid really worked to close a gap that existed in the 2008 Mental Health Parity and Addiction Equity Act. And so what the Centers for Medicare and Medicaid rule did was say that those changes in the 2008 legislation were also applied to Medicaid and the Children's Health Insurance Program. And so this helps to prevent inequity between beneficiaries who have mental health or substance use disorder conditions that are receiving Medicaid and CHIP. It also promotes greater cross-state consistency for individuals who are receiving health insurance coverage via these programs.